Okay, so hi everyone. My name is Drs Dutra. Today I have with me Madeline McCrary. We're gonna go through an AJOG MFM clinical practice update. So back in December, I published an article with one of our hepatologists here at Jefferson on hepatitis C treatment during pregnancy, time for a practice change. And since that time, we've gotten a lot of outreach on how we set up our clinical programs and different methods for treatment of Hep C in pregnancy. So we wanted to take some time today to go through our own experiences, what we know about the data so far, and kind of what we're looking ahead to in the future. So if we can share the slides, we'll get going on that. Okay, perfect. So as I mentioned, my name is Drs Dutra. I'm an assistant professor of reproductive infectious diseases in the Department of OBGYN at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. I'm trained both as an obstetrician and an infectious disease specialist. So our program here is set up that our patients get referred directly to me. We discuss hepatitis C treatment during pregnancy versus postpartum. I do all of the initial evaluation, the prescriptions for the medications, and then their follow-up, and I can also do their routine obstetric care at the same time. So we have an integrated practice model, and we'll talk a little bit about the different ways that you can set up your practice today as well. And I'll shoot it over to Madeline.
Hey, I'm Madeline McCrary. I'm an assistant professor in the Division of Infectious Diseases at WashU in St. Louis, Missouri. I am both ID and addiction medicine trained. The way that we set up our program here, we had a lot of intensive postpartum efforts working with maternal fetal medicine and OB, and then expanded to offering treatment in pregnancy through shared decision making in 2024. We've treated about 20 to 30 people now in pregnancy. And the way that our model is organized is that we have a health system-wide electronic medical record report that identifies women with detectable virus in pregnancy. We'll reach out to folks, and then we'll see providers and then patients. And we'll see patients by telemedicine, or we have integrated ID OB clinics in high-risk OB and the perinatal substance use clinic. So I do not do obstetric care myself. Try and integrate it into prenatal care as much as possible.
Perfect. All right, I'm going to move on to the next slide and let you take it off.
Yeah, so universal Hep C screening is now recommended in pregnancy, early in pregnancy and during each pregnancy. The big thing is to try and get a Hep C antibody test that reflexes to a quantitative PCR, which is oftentimes a hepatitis C RNA. If the antibody is positive, it'll be positive for life. So you can clear the infection, you can get treated, you can get reinfected. And so the real marker of an active infection is that RNA test. So if somebody has a positive antibody, but a negative PCR or RNA, that means that they spontaneously cleared the infection or they were treated. They do not have an active infection. If they have a detectable antibody and detectable virus, they have hepatitis C. And the one thing that we also wanted to be sure to bring up is that women can get acute Hep C during pregnancy. So if you have somebody that's screened, negative or for an antibody, but maybe has elevated AST or ALT either at that point or later in pregnancy without an obstetric cause, send off an RNA because you might be surprised, and that would be a case of acute hepatitis C.
Perfect. Yeah, and I think we started screening in 2020 universally, at least per ACOG recommendation. Some people had started before then. So we've been screening for a long time, but haven't really been addressing the hepatitis C infection in pregnancy for many years. So that brings us to the point of why we should offer and discuss treatment during pregnancy. I think of a few different considerations that we should take into account. First is that pregnancy is a time when people are really engaged in consistent care. They have access to specialty care more consistently. Patients may become eligible for insurance during this time, and they have a lower barrier of entry to care than they may otherwise have. So it's a great time to at least have a conversation with people about their Hep C infection and what their treatment options are. We should also be considering what the different possible benefits of treating during pregnancy are. So right now, in published cases of Hep C treatment during pregnancy, we haven't seen any cases of perinatal transmission. So far, the data is still early, so we don't have very large randomized controlled trials that are powered to say what the risk of perinatal transmission is, but we at least so far haven't had any documented transmissions, and we know that outside of treatment, the perinatal transmission risk is about 9% for those without a Hep C, without an HIV co-infection, and up to 12% for those who are co-infected. So the data is really promising that this may be a potential benefit. And then the other thing I think about is, can we reduce the risk of other adverse pregnancy outcomes that are associated with Hep C? So are we reducing the risk of preterm delivery, intrahepatic cholestasis of pregnancy? So all of these things need to be studied more in terms of larger scale studies, but I think right now what we have is really promising. The other thing we think about is initially we were diagnosing Hep C in pregnancy and offering referral to treatment postpartum, and studies have shown that this hasn't really been successful. Most programs have not been able to get postpartum treatment rates above 50%. So it's been challenging for people to continue to engage in care after delivery. They have multiple competing interests, including caring for a newborn and all that entails. So we're not really doing a great job of getting people access after. So can we get access to treatment during pregnancy and improve those patients' outcomes? And the last thing to think about is that this is a shared decision-making conversation. So we should be talking to patients and thinking about their individual situations and what might be best for them. They have to want to be treated, they have to take a daily medication, and they have to be willing to get lab monitoring. It's not a ton of lab monitoring, but there is still some kind of engagement that they need to continue to participate in, so that may or may not be the right time for them. So we were going to go a little bit through a treatment pathway. So you've tested someone during their routine pregnancy and they have a detectable RNA. So what do we do with that information? We've diagnosed them with chronic or active Hep C, and we have to decide, are we going to offer them treatment in pregnancy or not? So the first thing that we kind of discuss that we think about is, are there any treatment exclusions, so reasons that we wouldn't offer treatment during pregnancy? So Madeline, do you want to go through a couple of yours?
Yeah, I think the biggest one is if somebody has decompensated cirrhosis or a history of decompensated cirrhosis. There's just a lot of other considerations with that. And so that's something that I would defer to hepatology, but it's likely that that would get deferred postpartum. That's really the only specific exclusion to treatment for me. If somebody has a HIV co-infection, that might be even more of a reason to treat because the transmission rate goes up to like 20%. And same with hepatitis B, but hepatitis B might be something that, if I were a primary OB, I might want to have some specialist input on. But decompensated cirrhosis, in terms of general exclusions, is the number one. And then the second component is timing, but we can talk about that in a bit. How about you, Carly?
Yeah, I think that is also my biggest exclusion. I think most patients that we see tend to be younger reproductive age women, so they don't often fall into the decompensated cirrhosis bucket, but that would definitely be someone I would be calling our hepatology colleagues about. And then I personally would also be calling our hepatology team for any co-infected patients. Most of the things that we're thinking about are, drug-drug interactions and making sure that you're not reactivating Hep B in someone who winds up screening positive. But those are conversations that I think are a little more in-depth and take you away from the simplified treatment algorithm. So those are people I would definitely be having more conversations with, but aren't exclusions. And certainly there are many people who should be treated in those situations. If someone does have decompensated cirrhosis, we're most likely deferring to postpartum after having a conversation with hepatology. And then if there are no exclusions to treatment, we start getting into that shared decision-making conversation, and we're going to go through that in a little more detail later, but we did want to just address the timing of treatment during pregnancy. So my personal practice has been that we start treatment around 24 to 28 weeks ideally, so people are confirmed to have a normal anatomy scan. We're not worried about like an underlying congenital defect that could be caused by the antivirals, although we haven't seen that be a risk in the literature, but I personally feel more comfortable knowing we have a normal anatomy before we're starting treatment. And then the goal with the 24 to 28 week time period is that these medications are oral meds for 8 to 12 weeks. So you would finish the entire course before delivery. So there wouldn't be any exposure via breast milk. We have some limited studies that show the drug transfer through breast milk is low, but they haven't been huge studies, and not all of the drugs have been included in terms of published to date so far. So there are certainly people who, like if they have a preterm delivery or they get identified later in pregnancy, can start treatment and continue through breastfeeding. But in like an ideal scenario for me, we would start it and complete it before they deliver.
Yeah, and for us, we also wait until the second or third trimester. We don't intentionally treat in the first trimester. We do also wait until the anatomy scan. The anatomy scan doesn't necessarily like preclude treatment. It's mostly we don't want to start treatment and then get the anatomy scan and there be something on it and then somebody want to stop treatment because there's a finding and they're concerned it's related to the medication. So that's really the main reason. And then we'll start treating whenever the anatomy scan is done, so around 18 to 20 weeks. And same with Carly, we ideally we start around that time because then patients are done before delivery and you can get cure labs at the time of delivery, which is really challenging in the postpartum period. So that timing really works out. We don't have any concerns about people breastfeeding on direct acting antivirals. The estimated amount to get into breast milk is like less than 1%. And so and there's no data to suggest any harm from infant exposure. So we just counsel women on that, but we don't really have any hesitations about breastfeeding on treatment.
Perfect. Yeah, and I know in the past we had a lot of, before some of the breastfeeding data came out, there had been conversations about like deferring even postpartum treatment to after the breastfeeding time period. So I think that conversation has changed as well. So if someone decides they don't want to take treatment during pregnancy, it's not the right time for them, but they want to start immediately postpartum, that is still on the table. And I know in our institution, we will even offer to bring meds to the hospital so that they can go home discharged with their meds rather than needing to come for a follow-up and have another conversation. So that kind of expedited timing can be helpful for keeping people engaged in the process. Okay, cool. Any other thoughts on timing?
I don't think so. I just want to reiterate what you just said. We do the same thing in bringing meds to the hospital at labor and delivery, and we have found that the patients who actually get treated when deferring postpartum are the ones who are getting treated before anyways, and so the expedited or deferring after breastfeeding, and so the expedited treatment, regardless of breastfeeding, I think really catches the folks that would not get treated in the interval period and may not stay engaged in care for like 18 months.
Yeah, totally. Okay, so we just wanted to go through a little bit of what information you need before you can start someone on treatment. And we kind of broke it down into labs and cirrhosis assessment, checking for drug interactions, especially for people who have an HIV or Hep B co-infection, and then the different regimen choices that we have. So I can kick it off with labs. So in general, most of these labs are things that we get during pregnancy. So it's a pretty low lift from the OB side to add additional information. We're already screening people for HIV, syphilis, and hepatitis B. For folks who haven't had a triple screen before, the recommendation for ACOG is to do a Hep B core antibody, surface antigen, which is all of the information we would want in this setting as well. Everyone's getting a CBC, so really the only additional information you may need is the CMP.
Yeah, so we follow our kind of hepatitis C Bible, if you will, is hcvguidelines.org, which are the multi-specialty guidelines from the IDSA and AASLD, and they have simplified treatment protocols. We don't necessarily follow the treatment protocols themselves in pregnancy because pregnancy is an exclusion, but we do use it for the assessment part. And so a lot of our providers throughout the health system, have not started getting a lot of like the hepatitis B screening labs besides the surface antigen. And so we're pretty limited in what we might have available to us, except for what we need is specifically for treatment. And for that, we want evidence of an infection, so a Hep C RNA, a hepatitis B surface antigen, HIV testing, platelets with a CBC, and then an AST or ALT that comes with the CMP. So that's kind of all that we require, and then we recommend the rest.
Perfect, yeah. And then for cirrhosis assessment, we similarly follow the Hep C treatment guidelines in terms of how they structure the different assessments. At our institution, we use FIB4, which is a calculator that takes into account patient age, platelets, and their AST, ALT, and it spits out like a risk of cirrhosis number that you can use to assess if someone is like above or below the threshold. And then we personally try to get a abdominal ultrasound within the last year for our patients. I would say it's not an exclusion if we don't have it, but a lot of our patients have had access at some point and have it done. So that provides additional support on whether or not they have cirrhosis.
Yeah, same with Carly. We calculate a FIB4 using the labs that were available to us. Sometimes folks won't have AST or ALT just yet, just because they weren't obtained yet during like OB care. But a lot of people have labs in the system from before pregnancy, or we'll order them, or they'll be obtained by the time we see them the following time. So we use a FIB4. We take a patient history. So if they have prior symptoms that might be concerning for cirrhosis, we take that into account. And then we review any prior abdominal imaging. I think the tricky thing with the cirrhosis assessment in pregnancy is that there isn't really any non-invasive marker that's specifically been validated in pregnancy, if you will. I think, and Carly, correct me if I'm wrong, I think elastography is the one that has like the most data behind it for non-Hep C related conditions. But from our standpoint in reality, if the FIB4, if platelets are normal, AST and ALT are fine, they're young, elastography or imaging isn't going to change my decision making. And so it just might add another barrier for folks that have trouble getting to appointments.
Yeah, I think I have the same perspective. I do not routinely order elastography. It has been assessed in pregnancy and other conditions and has been found to be pretty accurate. There is some increased possibility of it showing cirrhosis in the absence of there actually being cirrhosis, just because the density of the liver does increase a little in pregnancy. So you could get some false positive risk, although I think it's very low based on the studies that I've read. But I agree, it's another barrier for people getting access to care that they need, and they're a priori a population that's pretty low risk for cirrhosis if we don't have any other of those initial kind of triggers or concerns. So we don't routinely go down that route either. Okay, cool. And then drug interactions, I mentioned a lot of times I'm thinking about this. Obviously, you want to get the med list for any patient that you're starting on a new medication to make sure that there's no interactions. But I think about this most in the HIV and Hep B co-infected populations. There are a lot of potential crossover there. So I always pop in the different medications that a patient's on and what you're choosing to treat with before I proceed for those folks. And definitely you want to know what your patient is taking before you prescribe these medications.
Yeah, and I think one thing to plug is neither of these, a lot of our patients may have acquired hepatitis C through substance use. Neither of these medications have any drug interactions with buprenorphine or, Suboxone, Subutex, Sublocade, or methadone. And really they have very limited drug interactions. And I guess the big one to be aware of for soft-vel is separating it from any acid blockers, which are used frequently in pregnancy. But yeah, I use the Liverpool interaction checker all the time.
Yeah, it's really super helpful and easy. And all of the drug interactions don't live in my brain, rent free. So I definitely double check on those.
Yeah.
Yeah. Okay, cool. And then I know you all at your program tend to use Maverick, so why don't you take us through kind of your experience with that?
Yeah, so we use the medication preferred by insurance. So unfortunately, health insurance dictates a lot of what we do in medicine these days. Yeah, so we have been using glucapavir, pibrenizumab, or Mavorite in pregnancy. That's the preferred regimen in Missouri. If people have Illinois Medicaid, we'll give them the option between the regimens because they can go for either. Um, we've had a great experience. It's 3 pills once a day, ideally with food for 8 weeks. We can provide the full course up front. We have a manuscript under review right now for a cohort of 10 women who were treated in pregnancy and completed treatment. And everyone has been, that we know of, has been cured or at least has had a undetectable viral load by pregnancy. Of the infants we have screening on, there haven't been any transmissions. There haven't been really any adverse or sort of safety concerns. Uh, uh, and there weren't any findings in animal studies. So, hopefully there'll be more data soon there's an impact study trial going on. So if you live in a city where impact has a GP clinical trial, be sure to send your patients there. But we've been using it and have had a great experience.
Nice. Yeah, the 8 weeks duration is also really nice. Um,
Yeah.
and the no refills. It depends on where you're practicing and what your
Yeah.
Medicaid insurance is on whether or not refills are required. But it's really great that you all don't have to worry about that.
Yeah, yeah, and I think too, and this will be the case for either regimen, but uh, it's good to have options for patient preference, but also shorter allows us to get those cure labs, which is really what we're looking for. Is like, did this medication work, and especially if somebody gets reinfected in the future. So.
Yeah, totally. We personally have a little more experience with Epclusa here. Just the original kind of data that had been published for DAA exposure in pregnancy had centered around soft valves. So we kind of went that route, and our Medicaid does not preferentially at this point force us into one or the other. So that has been relatively easy for us to get access to. We'll talk a little bit more about insurance and specialty pharmacies in a second, but I do think depending on what state you're practicing in and what the patient's insurance is, you may be limited in what is available during pregnancy and postpartum. So that will certainly dictate what you potentially offer. The other thing I wanted to point out is both of these regimens on the Hep C treatment guidelines are considered like first line, you don't need a genotype, pangenotypic regimens. So it's great. You can essentially follow pretty similar to what we're using for non-pregnant adults in pregnancy for what we're considering for these two regimens. So it keeps it, I think, simple and straightforward for us.
Yeah. And I think also to plug at Closer Softval is that Stork, there's available interim study data from them that include a lot of patients,
Yeah.
like 50 to 60 patients.
Mhm.
All are cured. There's been no transmissions and no episodes of cholestasis in pregnancy, which all of this is just so encouraging and just really props to the folks that made these studies happen.
Yeah. Yeah.
Yeah.
A lot of hard work going into that, mostly from the University of Pittsburgh.
Yeah.
Okay, cool. So I'm going to move on to the next one. So here, just wanted to touch base on having conversations with your patients. So you've identified that they have Hep C and pregnancy, and kind of what are the different components that we're thinking about. And I think we've touched on these a little bit already, but this is a shared decision-making conversation. Right now, we don't have treatment guidelines specifically to pregnancy that will, strongly guide us one way or the other. So a lot of it is going through with your patients what the diagnosis of Hep C means, what the treatment options are, what we know about treating in pregnancy in terms of drug exposure, infant safety, maternal safety, and perinatal transmission. And then also talking about, their options are to treat during pregnancy, to not treat at all, or to defer to postpartum, and really letting patients identify priorities for them and work within the space that they're in.
Yeah, we take a similar approach. I think, one thing that we've experienced is that people come in having strong opinions about what they want.
Mhm.
Some people are really concerned about safety. A lot of people are very concerned about the risk of perinatal transmission. And even though there isn't like data or powered to prove it prevents transmission, the evidence kind of suggests that. And similar to like HIV and hepatitis B. And so, we've had to walk people back from that and be like, listen, like, we don't know this for sure. Like, you still should get your infants screened for Hep
Right.
C.
Yeah.
And then some people are uncertain, and all of those are okay. I think there's qualitative literature out there on uh, uh, treatment in pregnancy and sort of patient perspectives. And there's, I don't have the quote in front of me, but one quote from one of the papers really stuck with me and is a reason why we offer treatment is just like people just want to be offered options. And a lot of people are upset that they haven't been offered options in the past. So I feel like this approach has been really key in our treatment program.
Yeah, I agree. I think, anecdotally from our experience, every time I bring it up with a patient, they are essentially very surprised that this hasn't been brought up to them before because they may have had, a pregnancy or two before this was offered at our institution or elsewhere, and they may be really surprised that this is on the table. So I think I've had patients where we have 2, 3, 4 conversations before we get to a decision on what they want to do because they're so taken aback that it's even a choice at the beginning that needs to settle first before you can kind of go into the nitty gritty. But I agree from what we know, patients have found it to be a really acceptable approach to treat during pregnancy, and there are a lot of potential benefits for some people.
Yeah, and to your point, Carly, to piggyback off of the comment about having multiple pregnancies where it's been identified before, we've seen that a lot too, of like,
Yeah.
screening in pregnancy, then, no interval treatment, re-identified, and we've had women who have had perinatal transmissions, and so it's a real thing that happens, and there's a lot of some women experience a lot of shame associated with even the risk of perinatal transmission because they feel like it's related to their history with substance use or just they don't want to give an infection to their infant. Even when counseled that it's babies can get treated too. So uh, yeah, I think just having these conversations is so important.
Yeah, definitely agree. Okay, so here we wanted to get a little bit into the nitty gritty of like someone has decided that they want to pursue treatment in pregnancy and kind of what are the steps that you need to take on an individual level and then like within your institution to make sure that this is successful. So we talked a little bit about when we're choosing the DAA that we're going to prescribe, that insurance may play into it. There's a really helpful website called the State of Medicaid Hep C Access, and it goes through state by state what requirements you may have. It's gotten much better in the last couple of years, but certain states had prior authorizations for Medicaid, only certain providers could prescribe treatment, certain requirements on substance use, treatment engagement, things that were all essentially barriers to care, and many states have removed those, which is awesome. But if you're curious on like how your own state is doing, that is a really helpful website because most of our patients are Medicaid insured. So yeah, you want to know kind of in your area what is the preferred regimen by Medicaid. And then we personally put all of our prescriptions through a specialty pharmacy, and the specialty pharmacists are incredible. They take care of any authorizations for private insurance. Here, we don't need authorization for Medicaid anymore, so they don't have to take care of that. And then they help coordinate refills for our patients, and typically meds are mailed. So having a close relationship with that team is really helpful. I think many larger hospital systems do have a specialty pharmacy associated with them. And if you're not sure, I do think that reaching out to the ID or hepatology departments, whoever offers Hep C treatment, they may have their own individual pharmacist to assist with this. So just kind of getting the lay of the land in those different departments will help you kind of decide what the best route for prescribing will be.
Yeah, our best friends are the clinical pharmacists.
Yeah.
We talk we talk with them all the time. It really, I feel like Hep C treatment, we have a dot phrase, honestly, that pulls in everything. And so it's having the conversation with the patient. And then the big lift is all the care coordination. Like people need to have a phone. We need their updated phone numbers. They need to answer the phone. And that sort of thing. And so the pharmacist is like, oh my gosh, they're our best friend. And there's a lot of like, even, for example, in Illinois, they don't have a prior auth, they do have refills, but they have managed Medicaid, and each managed Medicaid plan has a different preferred specialty pharmacy that you have to fill the medication through. So there's a lot of sort of these logistical nuances that we rely on the specialist or the clinical pharmacist to walk us through it, so we don't spend hours kind of chasing our tails with that. Um, uh, and then, yeah, most patients are Medicaid, but commercial insurance does require most times genotypes. There's little sort of tricks like that they're super helpful for, so you don't delay care or get stuck doing appeals.
Yeah, and our specialty pharmacy is also really great. Like I obviously am keeping a list of the patients that I'm treating and tracking when their labs are due, but the specialty pharmacy here does the same. So they, will prompt us and say, hey, we tried to reach out to this patient because they're due for their SVR and they, didn't answer the phone. And then that reminds me that I need to reach out to them again. So the care coordination back and forth at the beginning and the end of treatment is really, really great.
And Carly, I love your idea about, we're privileged in that we have our own ID, like clinical pharmacists that know all this. But I can imagine that if you have, a clinical pharmacist who does OB stuff, they might not know the specifics of this because you aren't doing it day in, day out. And so making friends with or having them make friends with the ID or hepatology or whoever does all the Hep C treatment at your institution, so you aren't reinventing the wheel, is just such a good idea.
Yeah, when I came to Jefferson, so where I had been previously, we had a hepatology-based clinical pharmacist who we kind of borrowed to help with our Hep C prescriptions. But when I came here, there had not really been a setup for treatment. So the first questions I was asking were, who's treating? Who are you using to get your prescriptions approved?
Yeah.
And our hepatology department used our like enterprise-wide specialty pharmacy, which makes it very easy because they kind of cover all the departments. You don't need to, get funding or clinical time for that sort of thing, but definitely asking around and seeing who's doing what. I think it's always interesting to me that hepatitis C treatment falls under hepatology and infectious disease. So depending on where you are, it may be a totally different practice. You just kind of need to make new friends and ask around so that you can get to the right answers. Okay, cool. And I think we talked a little bit about the DAA choice already. Just in terms of side effects for counseling, most of the things that I discuss for Mavorite and Epclusa are mostly like mild GI side effects, headaches, in general, nothing that someone who's pregnant maybe already isn't experiencing, unfortunately. So I give them a heads up that they may experience some of those things. They hopefully will be transient and not severe, but if they have any concerns, obviously let us know. And sometimes, additional antiemetics might be necessary to help get them through that time period. But in general, I've had, pretty minimal feedback on things being really intolerable.
Yeah, same. And the increase in GI side, I mean, I guess we don't really know for sure, but the sort of nausea, vomiting should decrease after a few days.
Mm-hmm.
But if it doesn't, we try and support them through it with other medications if needed.
Yeah, perfect. And then why don't you talk us through like when you're doing the repeat RNAs for a cure? So a SVR, like explain a little bit about what that is for the.
Yeah. So So the sort of FDA labeled time point for cure is what we call SVR, or sustained virologic response, at 12 weeks. So that is sort of the formal cure time point, and that means 12 weeks after finishing treatment. What clinical trials have shown and what the multi-specialty guidelines have kind of moved more towards and updated algorithms is something called SVR4. So getting labs 4 weeks after completing treatment. It is really hard to keep people engaged for 3 months after finishing a medication. And the concordance between those two in non-pregnant patients is like over 96%. In the patients where it wasn't concordant, there wasn't any rhyme or reason for it. So things have moved really towards SVR4. The clinical trials ongoing now, so STORK and IMPACT, are using an SVR12 endpoint because that's what the FDA says. So just consider that. So what we're doing in our cure labs is getting both. So we definitely try and get an SVR4, and then we'll try and get a 12 or like at delivery when we can. But it's been pretty challenging. We are pretty confident that an SVR4 is fine. Just because most of these women do not have advanced liver disease, which would make it more difficult for medications to penetrate the liver. So that's what we're doing. And yeah.
Yeah, I think we're doing the same. So we are, for the most part, trying to catch people when they come in for delivery because they're already getting labs. So that is akin to the SVR4. And then our goal is to also get an SVR12, but we similarly have a little bit of trouble getting people to come back for that last set of blood work. We also do an RNA 4 weeks into treatment. We've noticed that most people do convert to be undetectable by that time point, and it can be like really good positive reinforcement for patients that they potentially are reducing the risk of perinatal transmission. So I've had a lot of patients like say that time point is really helpful for them. They do need to still finish out the entire treatment course. So it's very important to talk about that before you get the lab because you don't want them to see it as undetectable and stop their meds. But we do offer that 4 weeks into treatment as well.
Yeah, we similarly are trying to get on treatment monitoring. It can definitely be positive reinforcement. Since we're not providing the OB care, I do think it can be confusing to like the primary obstetric provider sometimes when they see a negative viral load. So we similarly just reinforce to everyone, or at least try to, that like this does not mean you're cured. You need to finish the medication. But I think that's, in non-pregnant people, we've really moved away from doing any on-treatment monitoring. And so that could be, something in the future for pregnant women as well, depending on what kind of shakes out. But yeah, it's been a great motivator for folks.
Yeah, and then I personally don't do any LFT monitoring for people who start out normal baseline and we're not particularly worried about how they're reacting to the medication. I don't know if you all have a different system, but it's already kind of hard to get people to get labs, so we don't add to the burden personally.
Yeah, we had that, or we have that as part of our monitoring, mostly just because it was originally part of safety monitoring in Hep C treatment. But honestly, like, I wouldn't know what to do with it, and I think that it would be more identifying something obstetric than that what wouldn't have been identified through usual care. And I do kind of worry about getting those. So it's, the on-treatment monitoring is something that we've been going honestly back and forth about. We're getting LFTs right now, but I'm not really sure of the risk benefit ratio of that at this point.
Yeah, and I think obviously if there's a concern for another condition in pregnancy, preeclampsia, et cetera, then that would obviously be an indication to check. But yeah, I think in my mind, I don't really know what to do with that information in the absence of another clinical kind of concern. So I've been staying away from it. But I think, we don't have specific treatment guidelines in pregnancy. So a lot of this is expert opinion, and we don't really, have all of the full details settled out. So I think depending on what program you're trying to develop and what your patient population looks at may dictate a little bit on whether or not you're getting LFTs, and maybe your ID and hepatology colleagues at your certain place have a strong opinion. Okay, cool. And then we did just want to touch a little bit on perinatally exposed infants. So for folks who aren't getting treated in pregnancy, it's recommended that the baby get tested with a hepatitis C RNA test between 2 to 6 months of age, just to, rule in or out perinatal transmission. This is a change for the peds side. They used to do antibodies at 18 months, but screening rates are pretty poor at that long of a follow-up. So they have moved up the timing for babies. And right now, our recommendation is for people who have gotten treated during pregnancy, their infant should still be screened as if they've been exposed and not treated, because we, again, don't know entirely what the perinatal transmission risk is. We think it's going to be low once those studies are powered, and we haven't seen any cases of transmission, but in the absence of more data, I think that that's what we're recommending.
Yeah, screening is like less than 50%.
Yeah.
It hasn't been updated for the most recent CDC recommendation change, as that just happened like in 2023, but it's pretty poor. And so I think empowering parents to ensure this gets done, because their pediatrician might not be aware of those changes, and educating the pediatricians, if they aren't already aware at your institution, like put it into the discharge summary, is a great way to kind of disseminate these updated recommendations.
Yeah, and then the other thing that I've had a couple conversations with our Department of Health here is, so we have a Hep C program where they're trying to track infants who have been exposed and make sure that their pediatricians knows about the exposure so they can get appropriately tested. And we've been updating our Hep C program about all of the moms that we're treating, so that they know that even though there's an undetectable PCR at delivery, that baby still needs testing. So I think from the OB side that communication should definitely be there. And I think most OB offices have some sort of connection with the Department of Health, because we do have reportable diseases that we have to communicate back and forth in the HIV space, Hep C, Hep B. So hopefully you have a contact who you can touch base with and make it clear that baby still needs follow-up.
Yeah, I think one question that parents might have is like, well, what if it comes back positive? A lot of infants go on to clear the infection themselves, and they can get treated with the same meds we give adults once they turn 3 years old. So this is really something treatable in children as well. It's just a matter of like identifying it, and right now we're probably only identifying the tip of the iceberg.
Yeah, totally. And I think there's a lot of room for, more care coordination collaboration from the OB and ped side. I think that can be a bumpy connection at times. Okay, cool. Did you have any other last thoughts? I think that this is a topic that's obviously near and dear to my heart, and has been something that we have been really pushing for. I think we're finally at a point where hopefully more and more institutions start taking it upon themselves to offer treatment during pregnancy, and hopefully we've made the case of who we should be treating, how we should be treating, and kind of the success that we've all had.
Yeah, I think, about 3/4 of the folks that we've approached have wanted treatment in pregnancy. And so it's something that is pretty strongly desired by a lot of people. And since extending our program, as a health system wide, before we were doing this, only 14% of women were getting treated for Hep C by 6 months postpartum, like receiving a medication, and now 77% are. And so it really, there's few things in medicine that we can just cure that are like chronic infections. So it's very satisfying as a provider to be able to offer this to people, and then to cure someone, and nobody hates you for treating their Hep C. People love it. But really, like, breaking that cycle of recurrent exposed pregnancies and people not getting treated in between this is just going to be such a powerful approach. And Carly, I love that you're an OB and you're interested in this, and I hope more folks get interested in it too.
Yeah, totally.
Sorry to come back on. Social media has been on fire. This has been wonderful. I just wanted to show you, and this is the only way I can do it, that there are some questions from all over the world, including from Nigeria. Maybe, Carly, you can take the first question here.
Yeah. Yeah, so happy to. So yeah, what we do is we do the Hep C antibody with the reflex RNA at our initial prenatal labs for all of our patients. So the reflex RNA we mentioned at the beginning will only run if the antibody is positive. So it can identify someone who's spontaneously cleared an infection, been treated, or who has an active infection. So it's really the only way for us to identify these patients because most of them are asymptomatic.
A couple of other screens, and again, Madeline, maybe you can cover this. I know you guys covered this really well. Excellent session.
Treatment options. So there's two kind of frontline medications, Sofel, Epclusa, or GP Mavorite. So those are the two general treatment options. It's really whatever insurance covers, but those are the frontline treatments. And then is there a need for viral load or thresholds to trigger treatment? I don't think so. We don't really, unlike Hep B, there isn't a defined viral threshold. And Hep C viral loads fluctuate greatly. So we've had people who are like 1,000 one day and close to 1,000,000 the next. And so currently there's no threshold to trigger treatment. It's just you offer it.
Last one, and I'll disappear. Again, congratulations.
Yeah, good question. Yeah, so here the specialty pharmacy that coordinates our outpatient prescriptions will still receive the prescription from our team, and then they will essentially like mail it and bring it to the hospital, and then either one of the pharmacists can bring it to the bedside, or one of our nurses or resident physicians will go and get the med from the pharmacy.
Yeah, we send our prescriptions to our we have a infectious disease specialty pharmacy that in our clinic that's like located right across the street from the hospital. So somebody will bring it over once we send it. I think the other thing is just if it has to go to a different pharmacy is confirming phone numbers. You can give the patient the number to the specialty pharmacy, and then they have that information too if it needs to be like delivered to the home.
Yeah, I think updating addresses and phone numbers is really helpful. And even if a patient, maybe they don't have a consistent address where they're staying, if they have someone who's trustworthy and reliable where they can send the medicine and then go pick it up from that house. We've had patients who, send it to a parent or a cousin's house because that's, the address that's going to be most reliable for them. So it doesn't necessarily need to be where they're staying as long as they're able to get there. But yeah, some logistical things to definitely work out for people to make sure that you're fitting into their lifestyle and that they can get access to the things that they need.
A question from someone from Nigeria about treatment. And I don't remember what the specific question was, but one of my colleagues does cost effectiveness research and is writing up the paper now, but treating in pregnancy is like insanely cost effective. And no surprise. And so, I really wonder in the future for countries that may have more limited resources, if perhaps pregnant women will be a population that's prioritized for treatment because of that. So, yeah, global Hep C, we're probably underdiagnosing it across the world.
Yeah, I would be curious to see how that pans out in the future. And I think that it is really just a great time to get people access to care and treatment. And it's such a defined time period that people need to be on these meds that it's kind of a perfect global and public health initiative.
Yeah.
All right, perfect. Well, thank you for joining today. Hopefully people found this conversation helpful, and check out the AA SLD IDSA treatment guidelines, talk to your local ID and hepatology providers, and hopefully you can get things going at your institution.
Thanks for having me.
Yep, thanks.